Today's module is on cervical radiculopathy. This is commonly called a pinched nerve in the neck. Radiculo means root, like a radish is a root, and pathy means dysfunction of the root. It's important to try to identify this diagnosis early for a few reasons. One, patients are often in terrible pain. Two, if they have so-called red flags, such as worsening motor weakness or weakness of the arm, or problems with their gait, or excruciating pain or bowel and bladder involvement, that does require surgical referral and more advanced workup such as MRI scanning. The benefit of early diagnosis is exactly those things, but also that we can avoid unnecessary testing if we have a good clinical idea of what's going on with the patient. We will talk more about treatments when we get to the history and physical exam section of this module. Thank you. So here's a model of the neck, and you can see these orange structures represent spinal nerve roots coming out of the neck. And when you have radiculopathy, remember radiculo means root, like a radish is a root. It's a pinching or an inflammation of one or more roots. And that will typically cause pain down into the arm. Okay, so this is the brachial plexus, which is sort of the collection of these nerve roots coming together, traveling from the neck under the clavicle into the arm. And it's a bit of a wiring diagram, so that if the lower cervical nerve roots, C6 or C7, in other words down here, the lower part of the neck, if those are injured, it causes tingling towards the thumb and the middle part of the hand. If it's one of the upper roots, like C5, it'll cause numbness, tingling more towards the outside of the shoulder. And that's important to bear in mind as you do your neurologic exam. Patients typically have terrible pain, often worse in their arm. If they talk about marked weakness or uncontrollable pain, you might want to get something like a cervical MRI scan sooner rather than later and consider surgical consultation. If there are any red flag signs, such as they really are so weak they can't use their arm, or they have other involvement suggesting spinal cord injury, such as bowel or bladder dysfunction, abnormality of gait, that is so-called red flag, and surgical consultation is needed emergently. Very rare with this diagnosis, but you should keep it in mind. In terms of the physical exam, we put them through range of motion. Often extension will tend to cause some of their pain going down the arm, and you try to do the exam so you don't flare them up too much. You know, the first 20 years I was doing this, I'd sort of get through my whole exam, and after a while you learn, don't hurt the patient. I mean, really try to just be a little bit more gentle. I won't say 20 years, but maybe the first few years. So try to be respectful of the fact that the patient's in a lot of pain, and you should be careful not to provoke symptoms too much. The key diagnostic maneuver here is the so-called Sperling's test. And that is a test where you bring the neck into extension, lateral bending, and axial rotation. And that typically will cause pain, numbness, tingling into the arm, often simulating or reproducing their typical symptoms. Again, be gentle with Sperling's test. It's not highly sensitive, but it's very specific. In other words, if the patient has it, they have that abnormal test, they probably have the diagnosis. What you're really doing is you're kind of like bringing the patient over like this, and that's actually going to pinch that nerve opening down and provoke symptoms. You should, of course, always do your shoulder exam, and I've talked about that elsewhere. Generally, the shoulder exam will be reassuring, although if the radiculopathy is severe enough, even bringing the shoulder up might bring pain into the arm. There are occasional patients with radiculopathy, believe it or not, who feel more comfort when their arm is up. They actually have to sleep with their arm up. Rare, but probably a very specific finding. The key here is the physical exam, neurologic exam. So when we do the exam, this is C5 mostly, shoulder abduction. Okay. If that were weak on this side, we think of a C5 or C6 radiculopathy. Put your arm in like this. Biceps is also C5, C6. Triceps is more C7, push out, so the lower cervical nerve root. And then wrist extension, mostly C6, C7. Wrist flexion, mostly C7, C8. Finger extension, mostly C7, C8. And then we get into the intrinsic muscles. In other words, the muscle belly is in the hand. That's called an intrinsic muscle. And that's considered C8, T1, median and ulnar innervated. And the most common radiculopathy is sort of a C6, C7 distribution. From medical school days, we remember this. This looks like a big 6, or maybe in the video it's a backwards 6, I'm not sure. But remember that's C6, that's C5, C7, C8, T1. So that's our wiring diagram, if you will. So a lot of patients with radiculopathy come in literally with a numb thumb, or they might say it's more here. And so that's important to keep in mind. The most common levels affected by radiculopathy are C6 and C7. C5 is relatively rare, C8 and T1 are relatively rare. Sometimes you can't decide if it's more C6 or C7, and you can do some tease-out tests, like pronation. Don't let me turn the hand over. That'll be weak in a C7 radiculopathy, but intact with a higher C5 radiculopathy. And then supination, hold the hand up, that'll be a little bit weak with sort of a C5 radiculopathy. But those are finer points. Reflexes can be useful. I often find that they're sort of late findings, but when they are abnormal, for example, C5 radiculopathy, they'll be decreased in the biceps, and for lower radiculopathy, decreased at the triceps, more of a C7 level. And sensory exam can be actually fairly useful here. You would use a pinprick. Usually I use safety pins in my clinic, and we might march along. We always start on the good side. So let's say the patient complains of a numb right thumb. I would start here, and I compare this to, say, here. And they often feel like, yeah, it drops off there, doctor, just at the index finger. Should be fairly repeatable. It can give you some localization. In terms of treatment, it's not an easy treatment. Sometimes gentle mobilization, gentle traction can be helpful. The chiropractic community sometimes uses a decompression device, which can be helpful for some patients. If they're really acutely in pain, we might try a short course of oral steroids. We don't like steroids, but a short course can be quite helpful for patients. Again, if they have enduring signs, or especially if they have even some motor weakness, we might make a surgical referral if they're not improving. Sometimes home traction can be helpful, but again, the key here is to watch for surgical red flags, get an early diagnosis, get an MRI if they're not improving or if there are red flags, and consider surgical consultation if they're really suffering for months and months and you've made a good diagnosis.